pH is a fundamental concept in chemistry and biology that describes how acidic or alkaline a solution is. The term pH stands for potential of hydrogen or power of hydrogen, reflecting its measurement of hydrogen ion concentration in a liquid. The pH scale is a logarithmic measure of hydrogen ion concentration in a solution, ranging from 0 to 14. What makes this scale unique is that each single unit change represents not a simple arithmetic difference, but a tenfold change in actual hydrogen ion concentration. The mathematical basis for this comes from the pH formula. For example, neutral water with pH 7 has 10 to the power negative 7 moles per liter of hydrogen ions. Household bleach with pH 13 has 10 to the power negative 13 moles per liter of hydrogen ions, which is 1 over 1 million of water's concentration. This means that a linear scale would be impractical for representing such vast differences in hydrogen ion concentration. The logarithmic pH scale conveniently compresses these enormous variations into manageable numbers from 0 to 14. In biological systems, this has crucial implications, as a pH change from 7.4 to 7.3 or just 0.1 units represents a 26% increase in hydrogen ion concentration, enough to cause noticeable physiological effects. The human body maintains a tightly regulated pH balance. Blood pH is normally kept between 7.35 and 7.45, a slightly alkaline range essential for optimal physiological function. When pH drops below 7.35, the condition is called acidemia, indicating an excess of hydrogen ions in the blood. Conversely, when pH rises above 7.45, the condition is termed alkalemia, reflecting a deficiency of hydrogen ions. These shifts occur due to disturbances in the balance between carbon dioxide, a volatile acid regulated by the lungs, and bicarbonate, a base regulated by the kidneys. A buffer system is a chemical mechanism that resists changes in pH when acids or bases are introduced to a solution. They work by either absorbing excess hydrogen ions when acidity increases or releasing H ions when alkalinity rises, thereby stabilizing the environment. In biological systems, these buffers maintain the stable pH required for optimal enzyme function, protein structure, and cellular metabolism. The human body relies on three primary buffer systems: bicarbonate buffer system, phosphate buffer system, and protein buffer system. The bicarbonate buffer system is the body's primary mechanism for maintaining stable blood pH levels. It consists of a dynamic equilibrium between carbon dioxide, carbonic acid, and bicarbonate ions. The process begins when carbon dioxide dissolves in blood plasma and reacts with water to form carbonic acid, a reaction accelerated by the enzyme carbonic anhydrase found in red blood cells. This unstable carbonic acid then quickly dissociates into hydrogen ions and bicarbonate ions. When blood becomes too acidic, the reaction shifts leftward as bicarbonate binds with hydrogen ions to form carbonic acid, which then breaks down into water and carbon dioxide that the lungs exhale. When blood becomes too alkaline, the reaction shifts rightward as carbon dioxide combines with water to generate more carbonic acid, which dissociates to release needed hydrogen ions. The lungs and kidneys provide critical support to this system. The lungs regulate carbon dioxide levels through breathing rate, providing quick adjustment, while the kidneys manage bicarbonate levels and hydrogen ion excretion. The phosphate buffer system has a role in maintaining pH stability, particularly inside cells and in the kidneys. This system relies on two forms of phosphate ions, dihydrogen phosphate and monohydrogen phosphate, which exist in equilibrium. In the tubular lumen, monohydrogen phosphate from filtered disodium hydrogen phosphate binds with secreted hydrogen ions to form dihydrogen phosphate, which is excreted in urine. This reaction prevents excessive urine acidification, while each hydrogen ion excreted allows one bicarbonate to return to the blood, replenishing its buffering capacity. The sodium ions are reabsorbed, maintaining electrolyte balance. While less significant in blood plasma due to lower phosphate concentrations, it becomes crucial when other buffer systems are overwhelmed, such as in chronic kidney disease where bicarbonate reserves become depleted. The protein buffer system alongside bicarbonate and phosphate systems helps regulate pH levels in both intracellular and extracellular fluids. Proteins, particularly hemoglobin in red blood cells and plasma proteins like albumin, act as buffers due to their ability to donate or accept hydrogen ions. This buffering capacity arises from the carboxyl group and amino group. In alkaline conditions, the carboxyl group releases hydrogen ions, forming a negatively charged carboxylate. In acidic conditions, the amino group accepts hydrogen ions, forming a positively charged ammonium ion. However, its effectiveness depends on protein concentration and the availability of buffering groups. The Henderson-Hasselbalch equation is a formula used to estimate the pH of a buffer solution based on the equilibrium between a weak acid and its conjugate base. By this equation, we can predict that pH is directly proportional to the concentration of base and inversely to the concentration of acid. For bicarbonate buffer system, a modification of the Henderson-Hasselbalch equation known as van Slyke-Henderson-Hasselbalch equation is used to describe the relationship between pH to bicarbonate concentration and partial pressure of carbon dioxide. We can ignore the dissociation constant and the solubility coefficient of carbon dioxide to simplify the equation for use clinically. The pH is thus inversely related to carbon dioxide and directly proportional to bicarbonate. We will be using this relationship to interpret ABG. The body tightly regulates pH through coordinated actions of the lungs and kidneys. The lungs provide rapid adjustments by altering ventilation to control carbon dioxide levels, responding within minutes to pH changes through chemoreceptors that detect shifts in hydrogen, carbon dioxide, and oxygen. When chemoreceptors in the brainstem and major blood vessels detect rising carbon dioxide or hydrogen ion concentrations as occurs in acidosis, they stimulate faster, deeper breathing to expel more carbon dioxide. This process begins within minutes because carbon dioxide easily diffuses across the alveolar membrane. The elimination of carbon dioxide reduces carbonic acid formation in the blood, thereby decreasing hydrogen ion concentration. Conversely, in alkalotic states, reduced ventilation allows carbon dioxide to accumulate, increasing hydrogen concentration and lowering pH toward normal. The speed of pulmonary regulation makes it the body's first-line defense against pH imbalances, while its limitations, primarily the inability to excrete fixed acids or generate new bicarbonate, mean the kidneys must eventually contribute for complete correction. The kidneys provide a slower yet more comprehensive approach to pH regulation compared to the lungs. Over hours to days, they carefully restore balance through several coordinated actions. First, they conserve bicarbonate by actively reabsorbing it from the filtered fluid in proximal convoluted tubules, preventing its loss in urine. Second, they eliminate excess acid by secreting hydrogen ions, which combine with urinary buffers like phosphate to form compounds that can be safely excreted. We have already seen how phosphate buffer work. Third, and most significantly, the proximal tubule of kidneys generate new bicarbonate from amino acid metabolism. The ammonia generated from amino acid metabolism also traps hydrogen's ions, which is then excreted. ABG, or arterial blood gas sampling, is a medical procedure used to collect blood from an artery, typically the radial, brachial, or femoral artery, to assess oxygenation, acid-base balance, ventilation status, and metabolic status. The radial artery is the preferred site for arterial blood gas sampling due to its superficial location, ease of palpation, and the presence of collateral circulation that ensures adequate blood supply to the hand even if the radial artery is compromised. If the radial artery is inaccessible or unsuitable, other arteries like the brachial artery or the femoral artery can be used. For newborns, samples may be taken from the baby's heel or the umbilical artery shortly after birth. Before sampling from the radial artery, an Allen's test is mandatory to assess the patency of the ulnar artery and ensure sufficient collateral blood flow to the hand in case the radial artery is compromised. To perform Allen's test, instruct the patient to repeatedly clench and unclench their fist approximately 5 to 10 times to exsanguinate the hand. Apply firm digital pressure with both thumbs to occlude both the radial and ulnar arteries simultaneously, confirming successful occlusion by observing blanching of the palm and fingers. While maintaining compression of the radial artery, release pressure on the ulnar artery and observe the return of color to the hand. If the hand quickly turns pink within 5 to 15 seconds after releasing the ulnar artery, the Allen's test is positive, meaning indicating sufficient collateral blood flow through the ulnar artery. If the hand remains pale or takes longer than 10 seconds to regain color after releasing the ulnar artery, the test is negative, meaning the ulnar artery cannot compensate if the radial artery is blocked or damaged. So a positive test indicates it is safe to proceed with radial artery procedures, while a negative test suggests alternative access sites should be considered. However, studies have shown that the Allen test has limited diagnostic validity, with a sensitivity of 77% and specificity of 93%. It fails to predict ischemic hand events after arterial puncture and has only 71.5% inter-observer agreement. Therefore, it is not a reliable screening tool for assessing collateral circulation or predicting hand ischemia. A modified version of Allen's test called Barbeau test or pulse oximetry-based Allen's test, is more sensitive than the traditional Allen's test in evaluating collateral circulation. For this test, a pulse oximeter is placed on the patient's thumb or index finger, and the radial artery is compressed. The pulse oximetry waveform is analyzed for up to 2 minutes before and after compression. The Barbeau test classifies the waveform response into 4 types. Type A with no damping of pulse waveform before or after compression. Type B with damping with compression and normalization after releasing compression. Type C with complete loss of waveform with recovery within 2 minutes, and Type D with persistent loss of waveform. Types A, B, and C suggest adequate collateral circulation, making the patient suitable for transradial access. Type D waveform indicates poor collateral flow and is a contraindication due to the risk of hand ischemia. However, emerging evidence suggests a shift away from the Allen and Barbeau test towards more objective techniques such as Doppler ultrasound. Contraindications to ABG sampling can be grouped into absolute and relative contraindications. Absolute contraindications include performing ABG sampling at a site with local infection such as cellulitis or abscess, as this risks systemic spread of infection. Another absolute contraindication is the presence of an arteriovenous fistula or vascular graft in the target limb, as puncture can compromise vascular integrity. Limbs affected by severe peripheral vascular disease with absent pulses or critical ischemia should generally be avoided. Relative contraindications require careful risk-benefit assessment before proceeding. An abnormal Allen's test indicating inadequate collateral circulation contraindicates radial artery puncture due to ischemic risk. Patients with severe coagulopathy and thrombocytopenia or those receiving thrombolytics or anticoagulation therapy have increased bleeding risk. Anatomic distortion from scarring, hematomas or prior multiple punctures also constitutes a relative contraindication. In cases of hypotension or shock where peripheral pulses are non-palpable, alternative sites should be considered. Ultrasound guidance can mitigate many relative contraindications by enabling precise vessel localization, particularly in those with challenging anatomy. When no safe arterial access exists, a venous blood gas may serve as an acceptable alternative for most clinical purposes. Clinical meta-analyses and systematic reviews have generally supported the idea that venous blood gas analysis can be used as an alternative to arterial blood gas analysis, particularly when assessing acid-base status and carbon dioxide levels, but they also caution about its limitations, especially regarding oxygenation. As depicted in this table, venous blood gas measurements show a strong correlation with arterial blood gas for pH, carbon dioxide levels, bicarbonate levels, and lactate concentration. This makes venous sampling a clinically acceptable alternative for assessing acid-base balance, ventilatory status, and metabolic conditions in stable patients. However, venous blood gas is unreliable for evaluating oxygenation because the partial pressure of oxygen and oxygen saturation differ significantly from arterial values and show poor correlation. Begin by explaining the procedure to the patient and obtaining verbal consent. Check for any contraindications which we have discussed earlier and perform the Allen's test to ensure that the ulnar collateral is patent. Appropriate personal protective equipment including gloves, apron, and face mask should be worn during the procedure for infection control. Additionally, ensure that cleaning swabs, gauze, tape and an ABG sampling syringe is prepared. ABG sampling syringes, which vary between sites, are typically heparinized to prevent coagulation between sample collection and processing in the gas analyzer. If the syringe is not pre-heparinized, manually flush the syringe with 0.5 ml of 1:1000 heparin and fully eject it to avoid dilutional errors. Some syringes are self-filling, where the syringe is filled by the patient's blood pressure once the needle enters the artery, while others require the operator to withdraw the plunger to aspirate the sample. Position the patient's wrist in slight extension and supination using a rolled-up towel or pillow for support. Using your non-dominant hand to palpate and stabilize the radial artery between your index and middle fingers. With your dominant hand, insert the arterial sampling needle at the identified site at a 45-degree angle. Once arterial blood flow is confirmed either by self-filling of the syringe or a visible flashback, collect 1 to 2 milliliters of blood. Remove the needle and immediately apply firm pressure to the puncture site using a gauze pad to prevent bleeding. Finally, the syringe is immediately sealed to prevent air bubble introduction and gently rolled between the palms to evenly dissolve heparin and prevent clot formation. The sample is then immediately analyzed without delay. ABG errors can be grouped into pre-analytical, relating to collection and handling of sample, and analytical, resulting during the process of analysis. Pre-analytical errors can arise from improper sample collection, delayed processing or contamination. Analytical errors in blood gas analysis can occur due to temperature miscalibration. ABG analyzers are calibrated for analyzing samples at body temperature. Hypothermia falsely increases pH, decreases PaCO2 and raises PaO2, while hyperthermia lowers pH, increases PaCO2, and decreases PaO2 if the analyzer calibration is not corrected for the patient's actual body temperature. During sampling, air bubbles may be introduced into the sample, which can rapidly distort results by elevating the PaO2 as oxygen from ambient air enters the blood. The PaCO2 may also be lowered due to the dilutional effect of the air bubbles. Immediate expulsion of bubbles, sealing the syringe, and early analysis prevents air bubbles from mixing with the blood. Excess liquid heparin dilutes the sample, artificially reducing bicarbonate, PaCO2, and electrolytes like potassium, while insufficient heparin causes clotting. The clotted sample can obstruct the analyzer, rendering the sample wasted. Pre-heparin-coated syringes or pre-flushing with a minimal heparin volume and ejecting it fully ensures proper anticoagulation without dilution. Drawing adequate blood, for example, at least 1 milliliter of blood for 2 milliliter syringe is recommended to prevent blood clot. Delay in processing can happen when the sample is kept at room temperature or when it is improperly chilled. At room temperature, ongoing metabolism by red and white blood cells decreases pH and PaO2 with documented PaO2 drops of 40% within 20 minutes. This also increases PaCO2, lactate and glucose consumption. Prompt analysis within minutes or proper storage in an ice slows this degradation. Improper chilling, such as storing samples in direct contact with ice, increases gas permeability in syringes leading to oxygen loss. This causes reduction in PaO2. So the sample should be kept upright in an ice slurry and not in direct contact with ice. Sample contamination from conditions like extreme leukocytosis falsely lowers PaO2 as white blood cells consume oxygen. In such cases, immediate analysis of the sample will prevent WBC consumption of oxygen. The change in PaO2 should be accounted for patient's blood WBC count. Venous admixture, often from accidental venous sampling, mimics respiratory failure with low PaO2 and high PaCO2. Confirming arterial pulsation during puncture and using ultrasound for difficult punctures in obese or hypotensive patients can mitigate this problem. A typical ABG report contains 3 types of parameters: clinician-entered values, directly measured values, and calculated values. Clinicians must enter certain information like FiO2 and patient temperature because the analyzer cannot determine these factors on its own. The machine directly measures core blood gas values including pH, PaCO2, and PaO2 using specialized electrodes. Other important parameters like bicarbonate, base excess, oxygen saturation and anion gap are calculated by the analyzer using formulas as the measured values. Modern advanced analyzers can also directly measure additional metabolic markers like lactate and creatinine. The combination of these 3 data types allows for comprehensive assessment of a patient's oxygenation, acid-base status, and metabolic condition. In this video, we will be focusing on the oxygenation part. Oxygenation is the process of delivering oxygen to the body's tissues, beginning with pulmonary gas exchange where oxygen moves from the lungs into the bloodstream either binding to hemoglobin or dissolving in plasma. This is followed by oxygen transport through circulation, and ending with tissue perfusion where oxygen is released to meet cellular energy needs. The oxygenation parameters that can be obtained from an arterial blood gas analysis include directly measured values like the partial pressure of oxygen, as well as calculated indices such as the oxygen saturation, alveolar arterial oxygen gradient, PF ratio, the oxygenation index, and arterial oxygen content. Let's look at these parameters one by one. PaO2 measures the amount of oxygen dissolved in the blood plasma and not bound to hemoglobin. The amount of oxygen dissolved in blood is determined by Henry's law, which states that the concentration of a dissolved gas in a liquid is directly proportional to the partial pressure of that gas above the liquid. It is a direct measure of how well the lungs transfer oxygen from the air into the blood. So, it reveals problems in gas exchange. PaO2 is directly measured in an arterial blood gas. The normal PaO2 range for a healthy adult breathing room air at sea level is 80 to 100 mm of mercury. For older adults aged more than 60, the normal range adjusts slightly lower to approximately 70 to 100 mm of mercury due to age-related changes in lung function. When a patient receives supplemental oxygen, the expected PaO2 is estimated to be 5 times the FiO2 administered. Abnormally low oxygen levels in arterial blood is used to categorize hypoxemia as mild, moderate and severe levels. Mild hypoxemia is defined as a PaO2 between 60 and 79 mm of mercury. Moderate hypoxemia corresponds to a PaO2 between 40 and 59 mm of mercury, which typically necessitates the administration of supplemental oxygen. Severe hypoxemia is identified when the PaO2 is less than 40 mm of mercury, and is considered life-threatening and requires urgent medical intervention. Low PaO2 can occur due to various reasons, which can be grouped into 5 main categories based on the underlying physiological mechanism. The first category is hypoventilation, where reduced breathing leads to inadequate oxygen intake and carbon dioxide retention commonly caused by conditions like drug overdose, neuromuscular diseases, or chest wall abnormalities. The second group involves ventilation-perfusion mismatch, where uneven air and blood flow in the lungs results in poor oxygenation, seen in pulmonary diseases such as COPD, asthma, pneumonia, and pulmonary embolism. The third category consists of shunting, where blood bypasses the lungs entirely without being oxygenated, occurring in conditions like atelectasis, ARDS, or congenital heart defects. The fourth group includes diffusion impairment, where oxygen transfer across the alveolar membrane is hindered, typically caused by interstitial lung diseases like pulmonary fibrosis. Finally, the fifth category involves low inspired oxygen levels, which can happen at high altitudes or in cases of oxygen deprivation. Clinically, distinguishing between these mechanisms relies on evaluating the alveolar arterial oxygen gradient. Before we begin, let's look at the concept of oxygen cascade. The oxygen cascade describes the progressive decline in oxygen partial pressure as oxygen moves from the atmosphere or inspired gas to the mitochondria. The oxygen cascade begins with inspired air carrying an oxygen partial pressure of around 150 mm of mercury at sea level. As this air reaches the alveoli, the partial pressure drops to approximately 100 mm of mercury due to dilution by carbon dioxide and water vapor. Oxygen then diffuses into arterial blood, where its partial pressure is normally about 95 mm of mercury. When oxygen-rich blood reaches systemic capillaries, tissues extract oxygen, reducing the partial pressure to roughly 40 mm of mercury. Finally, within the mitochondria, oxygen tension falls to just 1 to 10 mm of mercury, where it drives cellular respiration. This stepwise decline in oxygen tension ensures efficient delivery of oxygen due to the partial pressure gradient from inspired air to the mitochondria. It also explains the presence of the alveolar arterial gradient, which is the topic of our video. So AA gradient is the difference between the alveolar oxygen partial pressure and the arterial oxygen partial pressure. It is used to assess the efficiency of oxygen transfer from the alveoli to the blood, and helps differentiate the causes of hypoxemia, which we will see later. As we can see, the alveolar arterial gradient is dependent on two variables. PaO2 is a direct parameter measure by the ABG analyzer. We discussed that in our previous video. PaO2 with the capital A, however, is a derived parameter and is calculated using the equation called alveolar gas equation. In the equation, FiO2 is the fraction of oxygen in the air the patient is breathing. It is 0.21 for room air, or higher if they're on supplemental oxygen. Next, PATM is the atmospheric pressure, which is about 760 mm of mercury at sea level but drops at higher altitudes. P-water is water vapor pressure inside the lung, which is always 47 mm of mercury due to body temperature. PaCO2 is the arterial partial pressure of carbon dioxide directly measured by ABG analyzer. It represents the carbon dioxide diffusing into the alveoli from the blood, which displaces oxygen and lowers alveolar oxygen levels. Finally, the respiratory exchange ratio R represents the ratio of carbon dioxide exhaled to oxygen inhaled at the level of the lungs. Under normal physiological conditions, this ratio is approximately 0.8. At the cellular level, this means that for every molecule of oxygen consumed during metabolism, approximately 0.8 molecules of carbon dioxide are produced. For quick clinical assessment when using room air at sea level, we can further simplify the equation. The normal alveolar arterial oxygen gradient typically ranges between 5 to 15 mm of mercury in healthy young adults breathing room air. The math given here is self-explanatory. As people get older, the AA gradient naturally increases due to age-related changes in lung function. A more precise age-adjusted formula suggests the upper limit of normal should be less than age by 4 mm of mercury. For example, a 60-year-old would have an upper limit of approximately 14 mm of mercury. In older adults, the gradient may be slightly elevated with values up to 20 to 25 mm of mercury sometimes being considered acceptable. When a patient breathes 100% oxygen, both alveolar and arterial partial pressures increase dramatically, and while we would expect the AA gradient to be maintained at 5 to 15 mm of mercury, it instead increases to about 50 to 100 mm of mercury due to several key physiological mechanisms. The primary factor is absorption atelectasis caused by nitrogen washout from alveoli, leading to alveolar collapse and shunting of blood flow. Additionally, the suppression of hypoxic pulmonary vasoconstriction allows more blood flow to poorly ventilated areas. Thus, the arterial partial pressure of oxygen is much lower than expected. Now let's look at how we assess hypoxia using AA gradient. In the previous video, we examined the 5 main underlying causes of hypoxemia, which were hypoventilation, VQ mismatch, shunt, diffusion impairment and low inspired oxygen. Using the AA gradient, we can further categorize these causes into two broad groups as hypoxemia with normal AA gradient and hypoxemia with widened AA gradient. Hypoxemia with a normal AA gradient occurs when a patient has low blood oxygen levels but maintains normal oxygen transfer efficiency between the alveoli and bloodstream. This clinical scenario indicates that the lungs themselves are functioning properly, and the hypoxemia stems from problems either with breathing mechanics or the oxygen content of inspired air. So the two primary causes of hypoxemia with a normal AA gradient are hypoventilation and low inspired oxygen. In hypoventilation, the patient isn't moving enough air through their lungs, leading to elevated carbon dioxide levels which displaces oxygen in the alveoli, reducing alveolar oxygen. The key feature here is that while both alveolar and arterial partial pressure of oxygen decrease proportionally, their difference remains normal because the lungs' oxygen exchange capacity remains intact. Common examples include opioid overdose, where respiratory drive is depressed, or neuromuscular conditions like myasthenia gravis that weaken breathing muscles. When hypoxemia is caused by low inspired oxygen, less oxygen enters alveoli, reducing the alveolar oxygen. Hence, the arterial oxygen content is also reduced. Despite this drop in oxygen, the AA gradient stays normal because the lungs themselves function properly, efficiently transferring whatever oxygen is available into the blood. Such a scenario can occur in high altitude where oxygen content in the air is low, or with faulty oxygen delivery systems in ventilator delivering hypoxic gas. Now with widened AA gradient, there is impaired oxygen transfer between the alveoli and pulmonary capillaries, which causes reduced arterial oxygen despite adequate alveolar oxygen partial pressure. It occurs when the lungs cannot properly oxygenate blood despite adequate ventilation and inspired oxygen. This widened gradient reflects one of three fundamental physiological disturbances, which are ventilation-perfusion mismatch, shunt physiology, or diffusion impairment. VQ mismatch is most common cause of widened AA gradient hypoxemia. It occurs when some lung regions receive ventilation without perfusion or perfusion without ventilation. The overall lung has areas with VQ ratios that are either too high or too low, reducing gas exchange efficiency. In COPD with significant airway obstruction, such as in chronic bronchitis, there is reduced ventilation in some areas of the lung while blood flow may still be present, leading to a low VQ ratio. This results in blood passing through alveoli that cannot properly oxygenate it, leading to hypoxemia. Whereas in severe emphysema, alveolar wall destruction can lead to a high VQ ratio because alveoli are hyperinflated and receive more ventilation. Despite this, the alveolar wall is destroyed, which impairs the surface area for gas exchange, leading to low oxygen in the blood. Another classic example of high VQ is pulmonary embolism, where blood flow obstruction creates well-ventilated but underperfused areas. A shunt occurs when blood flows through the lungs without undergoing gas exchange, leading to hypoxemia that doesn't fully correct with supplemental oxygen. This can happen through anatomical shunts, such as right-to-left cardiac shunts, where blood bypasses the lungs entirely. More commonly, physiological shunts arise when alveoli are unable to oxygenate blood due to disease such as in pneumonia, where alveoli are filled with pus or blood, ARDS where diffuse alveolar damage and edema impair gas exchange, or atelectasis where collapsed alveoli from mucus plugs or poor ventilation prevent oxygenation. In these cases, blood passes by non-functional alveoli, effectively shunting deoxygenated blood back into circulation, creating AA gradient of more than 30 mm of mercury. With AA gradient hypoxemia due to these causes show minimal or no improvement in PaO2 with 100% oxygen unless the underlying cause is treated. Diffusion impairment occurs when oxygen struggles to cross the alveolar capillary membrane efficiently, typically due to either thickening of the membrane or reduced blood transit time through pulmonary capillaries. In conditions like pulmonary fibrosis, the interstitial tissue thickens, creating a greater distance for oxygen molecules to travel between alveoli and blood. Similarly, in pulmonary hypertension, dilated capillaries and increased blood flow velocity reduce the time available for oxygen diffusion even if the membrane itself remains intact. The alveolar arterial gradient widens slightly at rest but expands significantly during exertion when increased cardiac output further shortens capillary transit time. Unlike a shunt, diffusion impairment responds partially to supplemental oxygen, though improvement may be limited under high metabolic demand. Finally, let's create an algorithm to assess hypoxia using AA gradient. When hypoxemia is suspected, the first step is to confirm low oxygen levels in arterial blood, typically defined as a partial pressure of oxygen below 80 mm of mercury while breathing room air. Once confirmed, the next step is to calculate the alveolar arterial oxygen gradient, which helps determine whether the hypoxemia stems from a lung-related problem or an issue outside the lungs. If the gradient is normal, we check the partial pressure of carbon dioxide to determine if the hypoxia is due to hypoventilation or reduced inspired oxygen. If the PaCO2 is normal, the hypoxia is due to low inspired oxygen concentration, which can be easily corrected by supplemental oxygen. If the PaCO2 is raised, it could mean hypoventilation or type 2 respiratory failure. In such case, managing underlying cause is necessary, though supplemental oxygen can be helpful too. If the gradient is widened, a 100% oxygen is administered and the ABG is repeated. If the oxygen level rises after 100% oxygen administration, the issue is likely a ventilation-perfusion mismatch, as seen in conditions like chronic obstructive pulmonary disease, ARDS, or pneumonia. If the oxygen level remains low, a shunt is probable, such as in severe pneumonia, severe acute respiratory distress syndrome and cyanotic heart disease. If oxygen levels drop during exercise, a diffusion limitation, such as pulmonary fibrosis, may be the cause. Before we begin with the main topic of the video, let's briefly look at how oxygen is transported in the blood. Oxygen is transported in the blood in two main forms. The majority of oxygen, about 98 to 99%, is carried by hemoglobin and the rest by dissolving in plasma. Each hemoglobin molecule can bind up to 4 oxygen molecules. The term arterial oxygen saturation refers to the percentage of hemoglobin in the blood that is carrying oxygen. For example, if the arterial oxygen saturation is 97%, that means 97% of the hemoglobin molecules are carrying oxygen. Mathematically, it can be expressed as hemoglobin carrying oxygen by total hemoglobin expressed in percentage. The remaining portion of oxygen transported dissolved in plasma is described by the partial pressure of oxygen in the arteries, which is a direct parameter measured by ABG electrode. While this dissolved oxygen contributes to the overall oxygen content in the blood, it is a very small amount and plays a much smaller role compared to oxygen bound to hemoglobin. For instance, each gram of hemoglobin can carry approximately 1.34 milliliters of oxygen. So, in a person with 15 grams of hemoglobin per deciliter, this adds up to about 20 milliliters of oxygen per 100 milliliters of blood when hemoglobin is fully saturated. Whereas the dissolved portion is a small fraction and can be estimated using the solubility coefficient of oxygen in plasma, which is 0.003 milliliters of oxygen per 100 milliliters of blood per millimeter of mercury. This constant represents how much oxygen dissolves in plasma for every millimeter of mercury of partial pressure. To calculate the amount of dissolved oxygen, this solubility constant is multiplied by the arterial partial pressure of oxygen. For example, if the partial pressure is 100 millimeters of mercury, the dissolved oxygen equals 0.003 multiplied by 100, which results in 0.3 milliliters of oxygen per 100 milliliters of blood. Despite this small amount being transported in plasma, the partial pressure generated by the dissolved oxygen plays a critical role in determining the oxygen affinity to hemoglobin. These two modes of transportation constitute the total oxygen carried by the blood, termed as total arterial oxygen content. Most ABG machines estimate SaO2 using the PaO2 value, which is actually the partial pressure generated by dissolved oxygen. Their relationship is described by the oxygen-hemoglobin dissociation curve. However, some advanced ABG machines do have built-in co-oximeter. Co-oximeters use multiple wavelengths of light to directly measure oxyhemoglobin, deoxyhemoglobin, carboxyhemoglobin and methemoglobin. This gives a true SaO2, not just an estimate. We won't go in depth about this method of measuring SaO2 here. The one we are concerned about here is the estimation of SaO2 from PaO2, as PaO2 reflects the pressure of dissolved oxygen in blood, which drives oxygen diffusion into red blood cells and binding to hemoglobin. The oxygen-hemoglobin dissociation curve describes the relationship between them. The sigmoidal curve shows that hemoglobin's ability to carry oxygen depends strongly on the surrounding oxygen pressure. In the lungs, where oxygen pressure is high, hemoglobin becomes nearly fully saturated with oxygen. As blood travels to tissues where the partial pressure is about 40 mm of mercury, hemoglobin releases some of its oxygen with saturation dropping to about 75%. The curve has two particularly important regions. First, the steep portion between 10 to 60 mm of mercury PaO2, where small changes in oxygen pressure cause large changes in saturation. This ensures efficient oxygen unloading to tissues that need it most. The second is the flatter portion above 60 mm of mercury, where hemoglobin remains highly saturated despite pressure changes to provide a safety margin for oxygen loading in the lungs. Please read on Bohr and Haldane effect to get an in-depth idea on why such things occur. To estimate SaO2 from a measured PaO2, we use mathematical models of this curve. The most common is the Severinghaus equation, which accounts for hemoglobin's changing affinity for oxygen at different pressures. However, this estimation makes several assumptions. It assumes normal hemoglobin function, standard blood pH and temperature, and no interfering substances. It works for healthy individuals but becomes unreliable in conditions which we will discuss next. When we consider the factors affecting SaO2, they fall into two key categories. The first one is the physicochemical conditions in the blood that alter hemoglobin's oxygen affinity, and the other one is the pathological interferences that disrupts normal oxygen binding or hemoglobin function. The chemical changes include acidosis, fever, or high 2,3-DPG levels in the blood, which shifts the oxygen-hemoglobin dissociation curve to the right for any given partial pressure of oxygen. When the curve shifts right, the SaO2 will be lower than expected at a particular PaO2 because hemoglobin more readily releases oxygen to tissues. Conversely, a left shift from alkalosis, hypothermia, or low 2,3-DPG means hemoglobin holds oxygen more tightly, resulting in higher SaO2 values for the same PaO2. Beyond these normal physiological variations, certain medical conditions and exposures can profoundly disrupt the expected PaO2 to SaO2 relationship. Carbon monoxide poisoning represents one of the most clinically important examples, where it binds to hemoglobin with much greater affinity than oxygen, shifting the curve to the left. This makes PaO2 appear normal because oxygen still dissolves in blood. And since SaO2 is calculated from PaO2, the saturation is also calculated as normal. In reality though, oxygen is displaced from hemoglobin by carboxyhemoglobin molecules. Other hemoglobin abnormalities, whether inherited conditions like sickle cell disease or acquired methemoglobinemia, similarly distort the standard oxygen saturation relationship. Corresponding to the oxygen partial pressure, oxygen saturation level can be used to classify hypoxemia as normal, mild, moderate and severe. In a healthy person breathing room air, arterial oxygen saturation should be more than 95%. This corresponds to a PaO2 of 80 to 100 mm of mercury represented on the flat part of the oxygen-hemoglobin dissociation curve. COPD patients have a lower SaO2 target of 88 to 92% because their respiratory drive relies on hypoxemia. So maintaining a higher target for COPD patients can blunt the ventilator response to hypoxia. SaO2 will also be lower in higher altitude due to lower atmospheric oxygen content. Mild hypoxemia, characterized by oxygen saturations between 90 to 94%, corresponds to a PaO2 of 60 to 80 mm of mercury. This degree of hypoxemia typically isn't immediately life-threatening but does require careful monitoring through repeated oxygen level checks and further investigation with X-ray or blood gas analysis if symptoms worsen. Moderate hypoxemia, with saturations of 85 to 89%, often indicates more serious conditions including severe pneumonia, worsening COPD, or early acute respiratory distress syndrome. At this stage, the PaO2 reaches 60 mm of mercury and causes rapid decline in tissue oxygen delivery. Immediate intervention with supplemental oxygen is required along with diagnostic tests to identify the underlying cause. Severe hypoxemia, where saturations fall below 85%, constitutes a medical emergency seen in critical conditions such as advanced respiratory distress syndrome or shock. Emergency treatment involves high-flow oxygen delivery, comprehensive blood gas analysis to identify potential poisoning or blood abnormalities, and preparation for mechanical ventilation if breathing becomes inadequate despite treatment. Lastly, let's remind ourselves that tissue oxygen delivery depends on two important physiological processes. The first is the transfer of oxygen from the lungs into the blood, which is reflected by PaO2. The second is the binding of oxygen to hemoglobin, represented by SaO2. With this understanding, we can develop a systematic approach to assess hypoxemia. Since oxygen diffusion into the blood represents the initial step in oxygen transport, we must first evaluate PaO2. If PaO2 is abnormally low, we should then calculate the alveolar arterial gradient to determine whether the underlying cause originates within or outside the lungs. Next, we need to verify whether the SaO2 values correspond appropriately with the measured PaO2 levels using the oxyhemoglobin dissociation curve as our guide. If the SaO2 and PaO2 values match, the cause most likely stems from impaired oxygen transfer in the lungs. If they do not match, we must consider the various factors that can disrupt their normal relationship as previously discussed. Arterial blood gas or ABG gives vital information about oxygenation, ventilation, and acid-base status. We have discussed the oxygenation part in previous videos of this playlist. In this video, we will look into the approach we take to interpret acid-base balance. An ABG reports pH, PaCO2, bicarbonate, PaO2, oxygen saturation, and a lot of other parameters that are either directly measured or calculated. So, before beginning interpretation, it is essential to verify the internal consistency of the ABG values to rule out sampling errors. This is checked using the Henderson-Hasselbalch equation, which mathematically relates pH, bicarbonate, and PaCO2 as follows. The measured pH from a blood gas test should closely match the calculated pH from the Henderson-Hasselbalch equation if the values of PaCO2 and bicarbonate are correct. To illustrate this concept, suppose the measured pH is 7.25, the PaCO2 is 60 mm of mercury, and the HCO3 is 26 milliequivalent per liter. We now use the Henderson-Hasselbalch equation to calculate the expected pH by using the measured bicarbonate and PaCO2. From the calculation, the calculated pH is approximately 7.26. Comparing the two, the measured pH is 7.25 and the calculated pH is 7.26, which is extremely close, differing by only 0.01 units. Such a minor difference is considered physiologically acceptable and confirms that the ABG sample is reliable and internally consistent. Here's another example. Let's say the pH is measured at 7.05, the PaCO2 is 30 mm of mercury, and the bicarbonate is 24 millimole per liter. Using the Henderson-Hasselbalch equation, the calculated pH is 7.259. Thus, the calculated pH and the measured pH is showing a significant mismatch. Now the question is, do we not trust the report if there is a mismatch between measured and calculated pH values? Well, the first example we saw is applicable for conditions with simple acid-base disturbances without major interference from unmeasured factors. Examples include uncomplicated respiratory acidosis such as in COPD, simple respiratory alkalosis due to hyperventilation, isolated metabolic acidosis like early diabetic ketoacidosis before severe ketone accumulation, and straightforward metabolic alkalosis from vomiting or diuretic use. In these situations, the relationship between bicarbonate, carbon dioxide and hydrogen ion concentration remains predictable, allowing the Henderson-Hasselbalch equation to accurately calculate a pH that closely matches the pH directly measured by the ABG machine. On the other hand, as shown in example 2, if measured pH and calculated pH mismatch significantly, the first step is to suspect a sampling error, such as air contamination, clot formation, or a delay in processing that allowed ongoing metabolism in the sample. If sampling error is unlikely, the next step is to consider technical problems with the ABG machine, including calibration or sensor issues. We have discussed these issues in ABG sampling video. Finally, if technical errors are ruled out, the mismatch may be due to true pathological causes such as the presence of unmeasured acids like lactate or ketones, which can disturb the acid-base balance in ways not fully captured by the standard bicarbonate and carbon dioxide measurements. These include severe lactic acidosis, advanced diabetic ketoacidosis with high ketone levels, renal failure with accumulation of sulfates and phosphates, and poisoning with toxins such as methanol, ethylene glycol, or salicylates. Mismatch is also seen in mixed acid-base disorder where multiple primary disturbances affect the bicarbonate and carbon dioxide levels simultaneously and unpredictably. For example, if a patient has both metabolic acidosis from sepsis and respiratory alkalosis from hyperventilation, the bicarbonate may be low and the carbon dioxide may also be low, but not in a manner that maintains a predictable ratio. Therefore, in mixed disorders, more advanced acid-base analysis methods, such as calculating the anion gap and using delta-delta assessment, are needed to understand the true underlying problems. We will discuss them in subsequent videos.
Hello everyone, welcome to the 7th video of the video series on ABG analysis. In this video, we'll look into some early steps used in interpreting ABG report. This slide shows the overview of what we will learn in this video. So let's get going. Before moving on to the actual approach to ABG analysis, let's recap what we learned in the previous video. In our previous video, we have seen why it was important to check the authenticity of the ABG report. For that, we used Henderson-Hasselbalch equation to check whether the pH measured by the ABG analyzer matches with the calculated pH which we derived through Henderson-Hasselbalch equation using bicarbonate and carbon dioxide. Please check this video too. Now, to systematically analyze acid-base disorders, we start by looking at the pH to figure out if the patient is acidemic, alkalemic, or in the normal range. Then we identify the primary disorder, whether it is respiratory or metabolic, by examining how the pH, PaCO2, and bicarbonate levels relate to each other. If it turns out to be respiratory issue, we then check whether it is acute or chronic by comparing the actual pH change to the expected compensation. For example, in acute respiratory acidosis, the pH drops about 0.08 units for every 10 mm mercury increase in PaCO2, while in chronic cases, it only drops around 0.03 units because the kidneys have time to compensate. Next, we assessed whether the compensation is appropriate. If it is not, that might point to mixed disorder. Keep in mind, respiratory disorders are compensated by kidneys adjusting bicarbonate, while the metabolic disorders are compensated by lungs adjusting carbon dioxide through changes in breathing. And if you are dealing with metabolic acidosis, we calculate the anion gap to figure out what kind of acidosis it is. We'll go deeper into each of these steps later in this video. Step 1 in interpreting acid-base disorder is to determine whether the patient is acidemic or alkalemic by assessing the pH value. A normal arterial pH ranges from 7.35 to 7.45. If the pH is less than 7.35, the patient is considered acidemic, indicating an excess of hydrogen ions or deficit in buffering capacity. In terms of blood gases, this reflects an excess of carbon dioxide, a volatile acid, or a deficiency of bicarbonate. Conversely, if the pH is greater than 7.45, the patient is alkalemic, which reflects a relative deficit of hydrogen ions or an excess of buffering components. This corresponds to either a reduction in carbon dioxide or an increase in bicarbonate. Step 2 involves identifying whether the acid-base disturbance is respiratory or metabolic in origin. For this, first we note the direction of pH change. Acidosis will reduce the pH and alkalosis will increase it. Once we know the direction of pH change, the next step is to identify which parameter, carbon dioxide or bicarbonate, is responsible for the observed change in pH. My preferred approach is to start by looking at the pH and PaCO2. If they move in opposite direction, for example, if pH is low and PaCO2 is high, or pH is high and PaCO2 is low, then it's a primary respiratory disorder. This is because carbon dioxide behaves as an acid. It reacts with water to form carbonic acid, which then dissociates to release hydrogen ions. Therefore, if carbon dioxide level rise and pH falls, or if carbon dioxide levels fall and pH rises, the disturbance is due to a respiratory cause. If there is no clear opposite relationship between carbon dioxide and pH, then we check whether the bicarbonate is changing in the same direction as pH. If bicarbonate moves in the same direction as pH, it suggests a primary metabolic disturbance. This is because bicarbonate is a base and its concentration directly affects the pH. When bicarbonate falls, pH falls, and when bicarbonate rises, pH rises. So they always move together in the same direction in metabolic disorder. We can also use the mnemonic ROME or Rome to remember this relationship. However, if pH, carbon dioxide and bicarbonate do not follow the Rome pattern, it suggests a mixed acid-base disorder, incomplete compensation, or an early disturbance before compensation begins. The third step is to determine whether the respiratory disturbance is acute or chronic. This distinction is important because the body responds differently depending on the duration of the disturbance. Acute respiratory disturbance occur rapidly due to a sudden change in CO2 levels, while chronic respiratory disorders develops gradually, allowing the kidney to compensate for the change. So in acute respiratory disturbances, the blood pH changes significantly by about 0.08 units for every 10 mmHg change in CO2 levels. This relationship can be expressed with this formula. In chronic respiratory disorders, the pH change is much smaller, only about 0.03 for the same change in CO2 levels, because over time the kidneys adjust bicarbonate levels to maintain a near normal pH. To confirm whether the respiratory disturbance is acute or chronic, we can also cross-check the expected change in bicarbonate levels alongside the pH shift. In acute respiratory acidosis, bicarbonate rises only slightly by about 1 millimole per liter, while in acute respiratory alkalosis, it falls by 2 millimole per liter, reflecting the body's limited initial compensatory capacity. In contrast, chronic respiratory disorders show more pronounced bicarbonate adjustment due to renal compensation, rising by 4 millimole per liter in acidosis or dropping by 5 millimoles per liter in alkalosis. Distinguishing acute from chronic respiratory disorders is essential for proper treatment and management. Acute cases develop suddenly and demand urgent intervention as the body hasn't had time to compensate. Chronic cases progress gradually, allowing renal adaptation, so they require different management. Clinically, patients tolerate chronic imbalances better than acute ones. From the treatment point of view, acute cases need management of ventilatory parameters to correct arterial CO2 levels, while chronic cases focuses on addressing the underlying cause and medications to manage symptoms. Step 4 involves checking for the appropriateness of the compensation. For respiratory disorders, we apply the 1-2-4-5 rule we have seen earlier. In acute respiratory acidosis, the bicarbonate level should increase by approximately 1 millimole per liter for every 10 millimeters of mercury increase in CO2 above the normal. If the rise in bicarbonate is less than this, it suggests an additional metabolic acidosis. In chronic respiratory acidosis, the kidneys have more time to compensate, so bicarbonate should increase by about 4 millimoles per liter for the same carbon dioxide elevation. A smaller increase would again indicate incomplete compensation. Respiratory alkalosis follows the same principles. The acute form shows bicarbonate decreasing by roughly 2 millimole per liter for every 10 millimeters of mercury decrease in CO2, while chronic version demonstrate a more substantial decrease of about 5 millimoles per liter due to renal adaptation. If bicarbonate levels do not drop as much as expected, this may point to a coexisting metabolic alkalosis. So in all these scenarios, if the compensation is not appropriate, we need to suspect mixed disorder. The expected level of bicarbonate change due to compensation can also be calculated with the mathematical formula. Here I have given a formula for calculating the compensation for acute respiratory acidosis. We will practically revisit all these concepts with clinical case scenarios in the next video. For metabolic disorders, we use different compensation rules. Metabolic acidosis triggers respiratory compensation through hyperventilation, where for every 1.2 mmHg reduction in CO2, bicarbonate reduces by 1 millimole per liter. Mathematically, we can predict the expected CO2 level using Winter's formula. If the actual CO2 is higher than this calculation predicts, it suggests the respiratory system isn't compensating adequately, possibly due to concurrent respiratory acidosis. Further, upon detecting metabolic acidosis on ABG, we need to further check for anion gap and delta ratio, which we will discuss in our subsequent videos. In metabolic alkalosis, the respiratory system should compensate by slightly increasing CO2 levels, typically about 0.7 of a millimeters of mercury for every 1 millimole per liter increase in bicarbonate. We can use this formula too. If the CO2 doesn't rise as expected, this may indicate additional respiratory alkalosis. Importantly, the body's compensatory mechanism never overcorrects the pH. If values suggest overcompensation, we should question the measurement or consider that we might be missing some part of clinical picture. The time frame also matters greatly, as renal compensation takes several days to reach its full effect, while respiratory compensation begins within minutes. That's all for this video. In our next video, we'll see some case examples and use the concept we have learned to analyze the ABG results. Hello everyone, welcome back. This is the 8th video of ABG interpretation series, and in this video, we'll look into some cases to revise what we have learned. I would highly recommend to watch the previous videos, especially the part 7 on approach to ABG analysis. Let's start with our first case. In our first case, we have a 65-year-old patient with acute COPD exacerbation with drowsiness. His ABG results are given here. So the first thing we notice is the pH of 7.3, which is lower than the normal range of 7.35 to 7.45. And this tells us immediately that the patient has acidemia. Now moving on to step 2, we need to determine whether this acidemia is primarily caused by a respiratory or metabolic problems. Here we examine the PaCO2 level of 60 mmHg, which is significantly higher than the normal range of 35 to 45 mmHg. Since CO2 is a respiratory acid, this elevation tells us that the acidosis is respiratory in origin. The bicarb level of 26 MEq per liter is within the normal range of 22 to 28, which further supports that this is purely a respiratory rather than a metabolic one. At this point, we have established the primary disorder as respiratory acidosis. Now, we need to assess whether this respiratory acidosis is acute or chronic. To determine this, we need to evaluate how much the pH and bicarbonate have changed in response to elevated CO2 level. In acute respiratory acidosis, the pH typically drops by approximately 0.08 for every 10 mmHg increase in CO2 above its normal level of 40 mmHg. We can use this relationship to calculate the expected pH or use formulas derived from it. I'll be using the formula and will do the same for other cases in this video too. Here the CO2 has increased by 20 mmHg from 40 to 60, so we would expect the pH to drop to 7.24. However, the actual pH is 7.30, which is slightly higher than the expected for a purely acute condition. Now let's check if it's chronic. In chronic respiratory acidosis, the kidneys compensate more effectively, causing the pH to drop by only 0.03 for every 10 mmHg increase in CO2. With a 20 mmHg rise, the expected pH would be 7.34. Here too, the actual pH of 7.30 does not match the expected level, suggesting it is not a chronic respiratory acidosis. So what is it? To solve this dilemma, we apply the compensation rules. In acute respiratory acidosis, the bicarbonate increases by about 1 mMq per liter for every 10 mmHg rise in CO2. With a 20 mmHg rise, the expected bicarbonate would be 26 MEq per liter, which matches the measured or actual value from the ABG reading. This confirms that this is an acute respiratory acidosis. At this point, we don't have to proceed further, but for the sake of learning, let's check if it is chronic too. In chronic respiratory acidosis, the bicarb should increase by about 4 MEq per liter per 10 mmHg rise in CO2, meaning we would expect a bicarbonate level around 32 MEq per liter. However, the actual bicarbonate is only 26 MEq per liter, which is much lower than expected for a chronic condition. Now we are sure that this is not a chronic respiratory acidosis. Given these findings, the blood gas is most consistent with acute respiratory acidosis. The pH is closer to what we would expect in an acute scenario, and the bicarbonate level matches the predicted acute compensation. While the pH is slightly higher than for pure acute prediction, this could also suggest very early compensatory changes, but it does not yet meet the criteria for chronic respiratory acidosis. Therefore, the primary interpretation is acute respiratory acidosis. Finally, we move on to the step 4 to check the adequacy of compensation. Since it is a case of acute respiratory acidosis, the compensation follows the same formula we use to cross-check the acuteness of the condition. With the expected bicarb matching the measured level, the compensation is appropriate for the acute respiratory acidosis. So it is a case of simple acute respiratory acidosis with no evidence of additional metabolic disorders. Alright, now let's go back and think through what we did and why we made those choices based on the physiological concepts we covered. The initial event in the acute exacerbation of COPD is the reduction in alveolar ventilation due to airway inflammation, mucus plugging, or respiratory muscle fatigue. As a result of this reduced ventilation, PCO2 rises rapidly, allowing CO2 to diffuse into the cell where it reacts with water through the following chemical reaction. This reaction leads to the accumulation of hydrogen ions, causing pH to drop sharply. Specifically, for every 10 mmHg increase in PaCO2, the pH decreases by approximately 0.08, creating respiratory acidosis. For ease, we did this calculation using the expected pH formula and got 7.24 as the expected pH. That means pH did not drop as much as we expected because the measured pH was only 7.3. But why didn't it drop to the expected pH level? This is because we have intracellular buffer systems like hemoglobin, proteins, and phosphates that binds excess hydrogen ions, limiting the pH drop. Such buffer systems immediately kicks in within minutes to hours to mitigate acidosis. We have discussed them in the first part of this video series. Also, along with it, the intracellular buffer system causes the newly formed bicarbonate to compensate for the pH drop. This is the reason why a small compensation with bicarbonate rise of 1 MEq per liter per 10 mmHg PaCO2 rise occur in the acute respiratory acidosis. Again, for this, we have used a formula to calculate expected bicarbonate and got 26 MEq per liter as expected bicarb, which exactly matched our measured value. So this is the reason our pH has stabilized at 7.3 and not the expected level. Also, this early compensation did not correct the pH to the normal value of 7.3 to 7.45, as these intercellular buffers, though instantaneous, does not have the capacity to completely correct the pH. So this was a case of acute respiratory acidosis, as we saw that bicarbonate rises matches the acute buffering that occurs in the early stage of respiratory acidosis. We have also checked why it wasn't a chronic condition. In chronic respiratory acidosis, persistent hypercapnia would trigger renal compensation. It usually starts at about 12 hours and peaks around 2 to 5 days. The renal compensation is more robust than intracellular buffers in retaining bicarb and excreting hydrogen ions. The result of this is the higher bicarbonate rise of 4 MEq per liter per 10 mmHg change in PaCO2. In our case, the expected bicarbonate rise would have been 32 MEq per liter if it was a chronic condition. Since our measured bicarbonate was 26, which was less than expected, we would certainly say it was not a chronic case. In case 2, we have a 24-year-old woman presenting with acute anxiety and hyperventilation during a panic attack. These are her ABG values. Looking at the report, the pH is high, meaning it is alkalosis, and PaCO2 is low and in the direction opposite to pH, indicating respiratory alkalosis due to hyperventilation. The next thing is to check for the expected pH. In respiratory alkalosis, for every 10 mmHg drop in PaCO2, the pH is expected to rise by 0.08 for acute and by 0.03 for chronic cases. I prefer this formula to calculate the expected pH. We get 7.5 and 7.43 as expected pH for acute and chronic, with former being closer to the actual pH of 7.52. In the interest of time, we can also just rely on bicarbonate to ascertain if it is acute or chronic. In our case, since bicarb is normal, we can assume that there hasn't been much time for metabolic compensation, which would reduce it further from the normal level. Anyhow, let's also look for the adequacy of compensation using the expected bicarbonate. In acute respiratory alkalosis, the kidneys doesn't have enough time to compensate. The rule is that bicarbonate drops by 2 MEq per liter for every 10 mmHg decrease in PaCO2. For our case, we expect the bicarbonate to drop to 21.6, which matches the actual bicarbonate level. In other words, compensation perfectly fits the acuteness of the disease. At this stage, we don't have to calculate for chronic compensation, but let's do it for completion. In chronic respiratory alkalosis, the kidneys excrete more bicarbonate to compensate. The rule is bicarbonate drops by 4 to 5 MEq per liter for every 10 mmHg decrease in PaCO2 level. Our actual bicarb is much higher than expected for chronic compensation for it to be chronic respiratory alkalosis. So the case given here is simple acute respiratory alkalosis from sudden hyperventilation during her panic attack. Let's move on to our next case. In our next case, we have a 60-year-old diabetic man with vomiting and lethargy presenting with cosmal breathing. ABG report is given here. The first thing the ABG reveals is acidemia with low pH of 7.25 with decreased bicarb of 12 MEq per liter. The reduced bicarbonate shows that acidosis is metabolic in origin. And if we look at the PaCO2, it also is low, which would suggest respiratory alkalosis, but it isn't as pH is low or acidic. The low PaCO2 is a result of compensation. In metabolic acidosis, for every 1 MEq decrease in bicarbonate level, the PaCO2 is expected to drop by 1.2 mmHg. This can be calculated using Winter's formula. So in our case, we would expect the PaCO2 to be between 24 to 28. And exactly the patient's actual PaCO2 of 28 mmHg is within the normal range, indicating adequate respiratory compensation. If somehow the PaCO2 was more than 28 mmHg, for example around 30 mmHg, it would be higher than expected compensatory range of 24 to 28 mmHg that we calculated. This would mean two things. The first thing is the incomplete compensation, where the lungs are not compensating enough, But for metabolic acidosis, these conditions are rare because the compensation is typically near complete in metabolic acidosis. So it would also mean concurrent respiratory acidosis, where a second disorder, for example due to hypoventilation, is preventing PaCO2 from falling much as it should. On the other hand, if the PaCO2 was less than 24 mmHg or lower than the lower limit of the expected, it means that lungs are blowing off more CO2 than needed to compensate for metabolic acidosis, or it would also mean the presence of concurrent respiratory alkalosis. So in our case, since this is a case of well-compensated metabolic acidosis, the next logical thing to do is to calculate anion gap to further categorize metabolic acidosis. This is our last case scenario, and we have a 55-year-old woman presenting with persistent vomiting for 3 days. She gives a history of chronic gastroesophageal reflux disease, and she has been self-medicating herself with excessive antacids. The ABG report is given here. So looking at the pH, it is alkalosis, and the increased level of bicarb points towards metabolic in origin. So our first guess is metabolic alkalosis. Her electrolyte also showed hypokalemia and hypochloremia, which are classic electrolyte finding in vomiting, reflecting loss of hydrochloric acid and potassium from gastric secretions. I have not mentioned those reports here though. Now, because of alkalosis, there should be respiratory compensation through hypoventilation to raise volatile acid carbon dioxide. In metabolic alkalosis, for every 1 MEq per liter rise in bicarb, PaCO2 is expected to rise to by 0.7 mmHg, and it's given by this formula. Plugging bicarb values into the formula, we get our expected PaCO2 as 45.6 mmHg. This is slightly higher than the actual PaCO2 of 42 mmHg. This suggests incomplete compensation, possibly due to mild concurrent respiratory alkalosis. So our ABG shows mostly metabolic alkalosis with near ideal or partial compensation. The slight PaCO2 discrepancy does not change the management, and treating the underlying cause like stopping antacid and correcting potassium deficit will correct them both. That's all for this video, and in our next video, we'll be looking into mixed disorders with cases like the one we did here. Thank you. First thing first, what is a mixed acid-base disorder? Well, it is also an acid-base disorder that occurs when 2 or more primary disturbances are present simultaneously in a patient. Here in the table, I have laid down some key differences between simple and mixed disorders. So unlike simple acid-base disorder with a single primary disturbance, mixed disorders come with multiple disturbances. The compensation in simple disorders is predictable, while mixed disorders have bicarbonate and PaCO2 values or their directions that do not follow compensation rules. In simple acid-base disorder, the pH typically shifts in one direction. It is either downward if the primary disturbance is acidosis, or upward if the disturbance is alkalosis. In contrast, because a mixed acid-base disorder involves 2 or more primary disturbances, the pH is dependent on the combined effect of the disorders involved. As a result, the pH may be normal if the opposing disorders balances out, or it can be high if the alkalotic process dominates, or low if the acidotic process dominates, making the diagnosis more complex. For example, an uncomplicated case of diabetic acidosis is a simple metabolic acidosis, while a patient with COPD and vomiting can present with respiratory acidosis mixed with metabolic alkalosis. We often see mixed disorders when diseases affect multiple body systems simultaneously. For instance, a COPD patient might develop respiratory acidosis And if the same COPD guy is on diuretics, it causes metabolic alkalosis through potassium loss. Most often, we also encounter mixed imbalances in critical illnesses when the body's usual compensation mechanism shuts off. Take sepsis as an example. The infection causes metabolic acidosis from lactic acid buildup, while the inflammatory response drives respiratory alkalosis through rapid breathing. As we can see, the system gets pulled in two different directions at once. Sometimes the body's attempt to fix one problem creates another. Consider a patient with vomiting. They lose stomach acid and develop metabolic alkalosis. But with repeated vomiting, dehydration happens, causing shock and then lactic acidosis. The kidneys try to fix alkalosis by peeing bicarbonate, contributing to more acidosis, and the lung tries to fix lactic acidosis by blowing off CO2, but then contributing to alkalosis. The point is, a whole lot of chaos can happen to our compensatory mechanism. Certain toxins and medication can also trigger multiple acid-base effects at the same time. Aspirin poisoning is a classic case where it causes metabolic acidosis by disrupting cellular energy production while simultaneously stimulating the respiratory centers to cause alkalosis. Lastly, the most dangerous situations occur when multiple organs fail together. A patient with kidney failure can develop metabolic acidosis and then later get pneumonia leading to respiratory acidosis. The point I'm trying to make here is mixed disorder can occur, and when it does, we should first know how to suspect it from patient's history and disease progression, and then acknowledge that the situation is more severe than simple disorders. Now, leaving these causes aside, we can simplify mixed disorders into two main types based on how the primary disturbances interact. The first one is the additive mixed disorder, which occurs when both disturbances push the pH in same direction, resulting in either extreme acidosis or extreme alkalosis. For example, respiratory acidosis and metabolic acidosis can occur together, leading to a life-threatening pH drop. The other type is the opposing mixed disorders that occurs when the disturbances push the pH in opposite directions. These may result in a near normal pH despite serious underlying disturbances. For example, respiratory acidosis and metabolic alkalosis when occurring together can balance out the pH, making it appear normal. And mind you, this is not only the way to classify mixed disorders. We can literally categorize them by just identifying the disorders like metabolic acidosis with respiratory alkalosis, or respiratory acidosis with metabolic acidosis, or we can also make it metabolic acidosis with respiratory alkalosis with metabolic alkalosis, you name it. Anyhow, another good way to look at the mixed disorder is to count the numbers of disorders present. So, mixed disorders can also be categorized as double acid-base disorder, triple acid-base disorder, and though extremely rare, even quadruple disorders can occur. Now, let's move to the main objective of this video. How do we approach mixed disorders? The approach to identifying mixed acid-base disorders follows the same basic steps as for simple disorders. These include looking at the pH, checking whether the disturbance is of respiratory or metabolic in origin, calculating the appropriateness of compensation, and so on that we have discussed in our previous two videos. Apart from that, even before we start the analysis, there are certain clues that can help us identify mixed disorders. The main clue is the history or the progression of the disease process that is causing the disorder. But my focus here is on the clues that we can take from the blood gas result at a glance. The first clue is to check whether the pH change is extreme with abnormal bicarbonate and CO2 that do not follow the compensation pattern. Remember that compensation follows the direction of primary disturbance. If somehow the compensation is in opposite direction to the primary disturbance, it indicates additive mix disorders, which push the pH to extremes. For example, in a mixed disorder with respiratory acidosis and metabolic acidosis, respiratory acidosis will raise CO2, but instead of increasing bicarbonate in the same direction as CO2, the metabolic acidosis will lower bicarbonate. And together, the two push the pH to extremely lower levels. If you remember, this is actually a feature of additive mix disorder. The second clue to identifying mixed acid-base disorder is the normal or near normal pH with CO2 and bicarbonate both deranged. At a glance, it will seem like the changes in CO2 and bicarbonate are compensatory. But mostly the values of these parameters are out of the expected range of compensation, though they change in the same direction. For example, in a case of metabolic acidosis with respiratory alkalosis, the metabolic acidosis will lower the pH through reduced bicarbonate, while respiratory alkalosis will increase the pH by reducing the PaCO2. So these two disorders cancels out the pH, making it appear normal. And if you remember again, this is what happens in opposing mixed acid-base disorders. Lastly, if the actual compensation deviates significantly from the expected compensation, a mixed disorder is likely. The deviation can either exceed or fall behind the expected range of compensation. For that, we use compensation formulas to check whether the compensation is appropriate. Please watch my earlier videos in the playlist to learn about the compensation rules. The link will be provided in the description. Alright, let's see some cases now. We have a case of 45-year-old man in ICU with sepsis. His ABG report shows pH of 7.38, PaCO2 of 22 mmHg and bicarb of 12 MEq per liter. The electrolyte reports are also given here, which we will use later to calculate anion gap. Let's take it step by step. The first step is to look at the pH to check if it's acidosis, alkalosis or normal. In this case, it is in normal range. The next step is to look if the PCO2 and bicarb are normal or whether some respiratory or metabolic changes are happening. Looking at them, both are deranged. Low bicarbonate point towards metabolic acidosis that would lower pH, and low CO2 point towards respiratory alkalosis that could increase pH. So the identified disorders at this moment here is metabolic acidosis with respiratory alkalosis cancelling out the pH. But could it also be due to compensation? So our next step is to look for compensation for each disorder. Let's do it for metabolic acidosis first. In metabolic acidosis, there will be respiratory compensation and we expect CO2 to fall. For this, we use Winter's formula to calculate the expected PaCO2. Plugging in the bicarbonate level of 22 into the formula, we would expect PaCO2 to reduce to 24 to 28 mmHg. But the actual or the measured PaCO2 of 22 is lower than expected for pure metabolic acidosis. This suggests that there is an additional disorder that causes CO2 to fall beyond the expected level, and that is respiratory alkalosis in our case. Now let's assume the primary cause as respiratory alkalosis, whereby we would expect renal compensation to reduce bicarbonate level. We are unsure of whether the respiratory alkalosis is acute or chronic, so we'll calculate the expected bicarb for both the situation. Again, I have to mention here that we have discussed compensation rules in our previous two videos. The simple math here shows the compensation for acute and chronic respiratory alkalosis at PaCO2 of 22 mmHg. In both scenarios, as we can see, the actual or the measured bicarb of 12 is much lower than we would expect with renal compensation, yet again suggesting additional disturbance, in this case metabolic acidosis. That was a pretty long approach that we could have avoided though, because if we look at the pH, we can appreciate that the pH of 7.38 is leaning more towards the acidic range, telling us that the metabolic acidosis is the dominant disorder. Knowing this, we would have been done calculating the compensation only for metabolic acidosis. Anyways, let's look at the electrolyte level that was provided in the case. We use these electrolytes to calculate the anion gap to further categorize metabolic acidosis into high or low anion gap metabolic acidosis. Some analyzers also provide the anion gap as derived parameters in ABG report itself. I'll not discuss in depth about the anion gap here, but this is how we do. The anion gap of more than 20 nearly always indicates that the metabolic acidosis is dominant, pulling the pH more towards the acidic side. Overall, this was a case of sepsis with high anion gap metabolic acidosis as a result of lactic acidosis as a dominant disorder. The lungs were trying to compensate but got hijacked by cytokine-driven hyperventilation, causing respiratory alkalosis. In case 2, we have a 60-year-old woman with COPD who got arrested, leading to respiratory failure and cardiogenic shock. Her ABG shows extreme acidemia with pH of 6.95. The high PaCO2 of 65 mmHg indicates respiratory acidosis from lung failure, while the low bicarb of 14 μQ per liter suggests metabolic acidosis. The direction of change of bicarbonate and PaCO2 is opposite, suggesting that there is no question of compensation. Both disorders point towards acidosis, and at such pH level, compensatory mechanism fails. In essence, there is no point in calculating the adequacy of compensation in such cases. But since we are taking a stepwise approach to ABG interpretation, let's calculate it to see why and how it fails. Let's do it for metabolic acidosis first using Winter's formula. So with the bicarbonate of 14 μQ per liter, we would expect the PaCO2 to lower to 29. As you can see, it is impossible to lower the PCO2 to such levels when a coexisting respiratory acidosis is raising the PaCO2. For respiratory acidosis too, the same situation occurs. The kidneys should be capable of raising the bicarbonate level to about 26 to 34 depending on the acuteness of the disorder to compensate for the PaCO2 of 65 mmHg. But due to metabolic acidosis, bicarbonate is nowhere available for compensation. So the net result is both disorders additively crashes the pH. That's all for this video. I would have done a case on a triple disorder in this video, but since it requires a clear understanding of anion gap and delta gap, I have pushed it for my next video. Alright, have a good day and see you soon with anion gap video. Let's begin with the physiological basis of anion gap first. The physiological basis of anion gap involves two important principles. These are electroneutrality and unmeasured ions. Physiologically, the body maintains a balance between positive and negative charges or ions in the body to ensure a stable cellular function. This means that the sum of all the positive charges or cations must equal the sum of all the negative charges or anions. The main cations in the plasma are sodium and potassium, while the main anions are chloride and bicarb. Together, these ions are called measured ions and are the major contributors to electrical neutrality. Now, these are not the only ions in our body. There are numerous other ions that contribute to plasma electroneutrality, but to a lesser extent. These are referred to as unmeasured ions. Albumin, phosphate, lactate, sulfates, and other organic acids are unmeasured anions, with albumin significantly contributing to anion concentration. Unmeasured cations include calcium, magnesium, and other trace elements. So the electrical neutrality in the plasma is the result of balance between all the anions and cations, whether measured or unmeasured. But if you exclude all the unmeasured ions, the concentration of cation exceeds anions because albumin, a major contributor to anion concentration, is excluded. The exclusion of cation, however, does not make much difference as it is significantly in low concentration compared to the measured portion. As a result, there is a difference or a gap of about 12 to 16 millimole per liter between the concentration of cation and anion. This difference between the concentration of measured cation and anion is called anion gap. It is calculated by subtracting the sum of measured cation concentration by the sum of measured anion concentration. The gap represents the concentration of unmeasured anions, especially albumin, but can include other unmeasured anions during metabolic acidosis. But how does this physiology relate to acid-base disorder and metabolic acidosis in particular? Well, in metabolic acidosis, there is a decrease in bicarbonate, which is a key measured anion. So any changes in bicarbonate can have an effect on measured anion concentration and thus on anion gap. There are two possible compensatory responses to the lowered bicarbonate level in metabolic acidosis. The first one is the increase in another major anion, chloride, to compensate for decrease in bicarbonate. The kidneys compensates by retaining chloride to maintain the balance of negative charges, thus maintaining the overall electrical neutrality. In this case, the anion gap does not increase because chloride is a measured anion and is accounted for anion gap calculation. This is what we refer to as normal anion gap metabolic acidosis, or NAGMA in short. It is also called hyperchloremic metabolic acidosis because of the increase in chloride ion concentration in the plasma. The other response to the reduction in bicarbonate in metabolic acidosis is the accumulation of unmeasured anions such as lactate, ketoacids, or toxins. In such metabolic acidosis, these acids releases hydrogen ions, which is buffered by bicarbonate, and this buffering reaction reduces the bicarbonate levels. Ultimately, the accumulated unmeasured anions takes the place of bicarbonate, increasing the anion gap and causing high anion gap metabolic acidosis, or HAGMA in short. Now let's look into the role of albumin in determining anion gap. As I've mentioned earlier, the concentration of measured cation is more than the measured anion because albumin, a measured unmeasured anion, contributes significantly to the total anion concentration. The normal anion gap of 8 to 12 or 12 to 16 millimole per liter is in essence due to the exclusion of albumin when we calculate anion gap. So depending on the albumin level, the normal anion gap can change. For every 1 gram per deciliter decrease in serum albumin, the anion gap decreases by approximately 2.5 to 3 millimole per liter. Therefore, in cases of hypoalbuminemia, the anion gap should be corrected to avoid underestimating the presence of unmeasured anions. The corrected anion gap can be calculated using this formula. Now, leaving the physiology behind, let's delve deeper. The two concepts that I am going to discuss here are used in the assessment of high anion gap metabolic acidosis. Let's take a look at the delta gap first. Delta gap or gap is the difference between the measured anion gap and the normal anion gap. It quantifies how much the anion gap has increased from its baseline of typically 12 millimole per liter. For example, if the measured anion gap is 22 millimole per liter and the normal anion gap is 12 millimole per liter, the delta gap is 10 millimole per liter. It quantifies the absolute increase in unmeasured anions such as lactate, ketoacids or toxins. However, the delta gap alone does not provide information about the other acid-base disorders, as it only measures the increase in unmeasured anions without considering the bicarbonate changes. Bicarbonate decreases in metabolic acidosis, and its inclusion in the assessment of metabolic acidosis is therefore crucial. This is taken care by another concept called delta ratio. Delta ratio is the ratio that describes the change in anion gap to the change in bicarbonate concentration. For example, if the anion gap is 22 millimole per liter and the measured bicarbonate is 19 millimole per liter, the delta ratio is 2. Normally, in high anion gap metabolic acidosis, the increase in anion gap is typically assumed to be matched by a corresponding decrease in bicarbonate, resulting in a ratio close to 1. So the delta ratio basically assesses whether the change in bicarbonate is proportional to the change in anion gap. And if we dissect the delta ratio in terms of simple correlation, it is directly proportional to anion gap, meaning the ratio increases with increase in anion gap. That's the numerator part of the delta ratio formula. With bicarbonate too, the relationship is proportional, meaning any reduction in bicarbonate reduces the delta ratio, because with reduced bicarbonate, the delta bicarbonate, the denominator part is increased. This relationship between bicarbonate and anion gap as expressed by delta ratio is used to identify normal anion gap metabolic acidosis and metabolic alkalosis that coexist with high anion gap metabolic acidosis. The table below shows the delta ratios for different disorders, and we'll look into them one by one next. Alright, we'll begin with the delta ratio of less than 0.4 and how it suggests a pure NAGMA or normal anion gap metabolic acidosis. We don't per se calculate anion gap or delta ratio for NAGMA because the anion gap does not increase in normal anion gap metabolic acidosis. However, when the patient has just a slight increase in anion gap, the calculation of delta ratio might point towards NAGMA more than the HAGMA. Let's look at the pathophysiology of NAGMA again. In NAGMA, the primary issue is the loss of bicarbonate without an accumulation of unmeasured anions, hence the anion gap remains normal. The most common cause of normal anion gap metabolic acidosis is severe diarrhea, where there is a loss of bicarbonate-rich fluid, and renal tubular acidosis, where kidney fails to reabsorb bicarbonate. In this condition, the loss of bicarbonate is not accompanied by a corresponding increase in unmeasured anion, but rather by chloride to maintain electrical neutrality. So the anion gap changes minimally while the bicarbonate drops significantly, resulting in a low delta ratio. I hope you can correlate how low bicarbonate and normal anion gap causes low ratio from the relationship we discussed earlier. For example, in the given scenario, the patient has an elevated anion gap of 14 millimole per liter and the bicarbonate of 6 millimole per liter. So the delta gap is 2 and the delta bicarbonate is 18. The delta ratio is 0.11, which indicates that the decrease in bicarbonate of 18 millimole per liter is disproportionately greater than the increase in anion gap of 2 millimole per liter. But this is not what we expect in HAGMA. In HAGMA, we assume that the bicarbonate and the anion gap changes at a ratio of 1:1 or close to that. So, though this case has a slight increase in anion gap, upon further assessment with delta ratio, the case seems to be predominantly normal anion gap metabolic acidosis. At such a level of delta ratio, the disorder can be considered as normal anion gap metabolic acidosis, ignoring the coexisting high anion gap metabolic acidosis. Next, we have a delta ratio between 0.4 and 0.8, which point towards the mixed disorder involving HECMA and NECMA. Let's revisit the pathophysiology of HECMA again. In HECMA, the decrease in bicarbonate is compensated by a proportionate increase in unmeasured anions, resulting in the increased anion gap. So we would expect the delta ratio to be 1 or very close to 1. But when the ratio is between 0.4 to 0.8, it indicates that the decrease in bicarbonate is still disproportionately greater than the increase in anion gap. This suggests that there is a coexisting NECMA which also loses bicarbonate without being compensated by increase in unmeasured anions. NECMA is compensated with measured anion chloride. So the combined effect of two together is the loss of bicarb, which is significantly more than the increase in anion gap, thereby reducing the delta ratio. Let's take an example again with the patient's anion gap of 18 millimole per liter and bicarbonate of 8 millimole per liter. With this, we get a delta gap of 6 and a delta bicarb of 16. The delta ratio is therefore 0.375 or close to 0.4. The increase in anion gap or the delta gap of 6 millimole per liter suggests a mild high anion gap acidosis. Along with it, the substantial bicarbonate decrease of 16 millimole per liter is far greater than expected for the anion gap increase, indicating an additional normal anion gap metabolic acidosis. Moving on, we have pure HECMA where the delta ratio should fall between 0.8 and 1, meaning that the increase in the anion gap and the decrease in bicarbonate are well matched. Normally, when 1 millimole per liter of unmeasured acid like lactate and ketones accumulates, it consumes 1 millimole per liter of bicarbonate. So the anion gap increases by 1 millimole per liter and bicarbonate decreases by 1 millimole per liter proportionately. Let's take an example with an anion gap of 30 millimole per liter and bicarb of 6 millimole per liter. As you can see, the change in anion gap and bicarbonate is both 18 millimole per liter, giving the delta ratio of 1. Even when the delta ratio exceeds 1 but remains below 2, it is still considered pure HECMA in some interpretations. Ratio between 1 to 2 indicates that the rise in anion gap is slightly greater than the fall in bicarbonate. This occurs because the body's buffering system extends beyond just bicarbonate buffering system. Non-bicarbonate buffers, including hemoglobin protein and phosphate buffer system, also absorbs or buffer some of the acid, meaning less bicarbonate is consumed than would be expected from the anion gap increase alone. As a result, the bicarbonate level does not decrease as much as anion gap rises, creating a delta ratio between 1 and 2. So, this ratio range still represents pure HECMA. The causes of HECMA can be summarized by the mnemonic mud piles. Lastly, a delta ratio greater than 2 strongly suggests the coexistence of a concurrent metabolic alkalosis. This elevated ratio indicates that the observed decrease in serum bicarbonate is significantly less than what would be expected from anion gap increase. This happens because metabolic alkalosis is actively opposing the bicarbonate consumption from the acidosis. So, while the unmeasured acids like lactate and ketones are consuming bicarbonate and raising anion gap, another process like vomiting, diuretic use or alkali ingestion is simultaneously generating new bicarbonate. The numerator delta gap becomes disproportionately large compared to the denominator delta bicarbonate because the anion gap increases substantially from acid accumulation. Thus, this creates the mathematical ratio greater than 2. Before starting with the cases, let's check where we are from the ABG algorithm point of view. The ABG interpretation begins with ascertaining whether the ABG report shows acidosis or alkalosis. Next, we check whether the primary disorder is respiratory or metabolic in origin based on the PaCO2 and bicarbonate level. If the primary disorder is respiratory, we check whether the nature of disorder is acute or chronic using expected pH formula. And finally, we check for the appropriateness of the compensation, cross-checking with the compensation rules that we have seen in the earlier videos. Now for metabolic acidosis, we go further with anion gap and classify the metabolic acidosis into high or normal anion gap metabolic acidosis. If it is high anion gap metabolic acidosis, we proceed further with delta ratio to check for coexisting mixed disorders. Alright, for our first case, we have a 50-year-old male presenting with the symptoms of diabetic ketoacidosis, vomiting, and pneumonia. The ABG report is given here. Looking at the low pH, it's a case of acidosis. A bicarb of 12 MEq per liter suggests a primary metabolic acidosis, and a PaCO2 of 30 mmHg indicates respiratory compensation by hyperventilation. So let's check if this compensation is appropriate. Using Winter's formula, we get the expected PaCO2 for pure metabolic acidosis as 26 plus minus 2 mmHg. But the actual pH of 30 mmHg exceeds this range, meaning that PaCO2 is not lowered enough to compensate for metabolic acidosis. In other words, there is an additional respiratory acidosis, likely from impaired ventilation due to pneumonia. Now, whenever we have metabolic acidosis, we have to check for anion gap. The anion gap is calculated by subtracting the sum of chloride and bicarbonate concentration from the sodium concentration. Our case had a sodium of 135, chlorine of 85 and bicarb of 12 MEq per liter. With this, we get our anion gap of 38, which is higher than the normal level of 8 to 12 MEq per liter. A high anion gap means that there are some unmeasured negatively charged ions present in the blood, which can indicate a buildup of acids. In our case, the buildup of acid is due to ketoacids. So, the metabolic acidosis we have is high anion gap metabolic acidosis, or HAGMA in short. We are still not done. Detecting HAGMA means we need to proceed further with delta ratio to check if there is any additional metabolic disturbances. Delta ratio is calculated as measured anion gap minus normal anion gap divided by normal bicarb minus measured bicarb. It basically compares the change in anion gap to the change in bicarbonate, because in pure HAGMA, the increase in anion gap is expected to correlate with the proportional decrease in bicarbonate. We get a delta gap of 2.2 in our case. A delta ratio above 2 indicates that the reduction in bicarbonate is disproportionately lower for the observed increase in anion gap. A superimposed metabolic alkalosis can cause an additional loss of bicarbonate, which is why we see the delta ratio increasing. The cause of metabolic alkalosis in this scenario can be attributed to vomiting and loss of gastric acid. The pathophysiology behind respiratory alkalosis increasing delta ratio was discussed in the previous video. So in summary, this patient had a high anion gap metabolic acidosis, likely due to diabetic ketoacidosis, a secondary metabolic alkalosis from vomiting, and a tertiary respiratory acidosis, which was caused due to inadequate respiratory compensation or hypoventilation. Let's move on. In case number 2, we have a 50-year-old man with a history of chronic alcohol use and diabetes presenting with altered mental status and deep breathing. He also had multiple episodes of diarrhea since then. His electrolytes and ABG results are given here. Following the algorithm, we first check the pH and it is acidic. The low bicarbonate level points towards metabolic nature of acidosis, and the low PaCO2 in the same direction suggests a respiratory compensation. So a quick glance at blood gas report suggests a primary metabolic acidosis with respiratory compensation. Next, we check whether the respiratory compensation is adequate by calculating the expected PaCO2. We use Winter's formula for this. We get our expected compensation between 22.5 to 26.5 mmHg. The measured PaCO2 of 25 mmHg is well within this expected range, meaning the compensation is appropriate. The third step in metabolic acidosis assessment is to check whether the anion gap is elevated. For this, we use our electrolyte levels. With this, our anion gap of 12 is within the normal range of 8 to 12 millimole per liter, suggesting normal anion gap metabolic acidosis. But our patient has an albumin level of only 1 gram per deciliter, which might reduce the anion gap. For every 1 gram per deciliter fall in albumin, the anion gap reduces by 2.5 millimole per liter. So we need to calculate the anion gap, correcting it for low albumin. The corrected anion gap is given by this formula. We take 4 gram per deciliter as normal albumin level, after which our corrected anion gap is 19.5 millimole per liter. Now, corrected anion gap of 19.4 suggests high anion gap metabolic acidosis due to the accumulation of keto acids. The final step is to check whether the reduction in bicarbonate and the increase in anion gap are proportionate. This is because in HAGMA, we expect the rise of unmeasured anions like keto acids that increase anion gap to equally reduce the bicarbonate. This is expressed by delta ratio, and we expect it to be 1 or close to 1 for a pure high anion gap metabolic acidosis. We have gone through the physiology of anion gap and delta ratio in our previous video. The delta ratio is calculated with this formula. We get 0.58 and this falls between 0.4 to 0.8, implying the presence of concurrent normal anion gap metabolic acidosis or NAGMA. In our case, it can be due to diarrheal episodes causing additional loss of bicarbonate. This additional loss of bicarbonate is not compensated by rise in unmeasured anions like lactate and keto acids, but with chloride. And so the rise in anion gap is limited, though the bicarbonate is lost. The anion gap is only increased due to keto acids accumulation, while the bicarbonate loss occurs due to two processes, one by keto acid buffering by bicarbonate and other through diarrheal loss of bicarbonate. Hence, the bicarbonate loss is more than the anion gap increase, giving us a lower ratio. So the final diagnosis for this case is high anion gap metabolic acidosis with concurrent normal anion gap metabolic acidosis. Please do watch the previous video to understand this more, as these cases are the part of masterclass on ABG interpretation. We'll do one more case. A 65-year-old patient with CKD presents with vomiting and confusion. Initial labs are given here. Looking at the ABG, the pH and bicarbonates are both low. So it is a metabolic acidosis, and the low PaCO2 in the same direction as bicarbonate indicates respiratory compensation. The compensation for metabolic acidosis is also appropriate as shown here. We now check anion gap as the disorder is metabolic acidosis. An anion gap of 17 is elevated, so acidosis is high anion gap metabolic acidosis. We can rely on this anion gap as albumin is also in the normal range. Lastly, we check whether there are additional disorders along with high anion gap metabolic acidosis using delta ratio. The delta ratio of less than 0.4 reveals that NAGMA is a dominant disorder despite elevated anion gap. So here we have a normal anion gap metabolic acidosis due to renal tubular acidosis as a primary disorder, with elevated anion gap metabolic acidosis as a secondary disorder. The elevated anion gap metabolic acidosis is due to uremic anions that raises the anion gap. As always, let's begin with the physiological basis. The two main systems involved in acid-base regulations are respiratory and renal systems. The respiratory system controls CO2, a volatile acid, and the renal system regulates bicarb and other non-volatile acids and bases. The two components are linked by the bicarbonate buffer system that occurs particularly in RBCs and is given by this reaction. This reaction is reversible, meaning that it can kickstart from either the CO2 side, which is a respiratory component, or from the bicarb side, the metabolic component. However, when dealing with base excess or deficit, we are concerned about the metabolic side because it directly affects the concentration of bicarbonate or base. Now, what does this mean? Let's look at the respiratory side to see why it is ignored first. As we can see, the reaction can start from the respiratory side affecting bicarbonate level. For example, when PaCO2 increases, CO2 reacts with water to form carbonic acid, which then dissociates into hydrogen and bicarbonate. The pH can become low due to hydrogen ion accumulation, but the concurrent bicarbonate rise ensures that the pH is normalized because bicarbonate buffers hydrogen. Here the rise in bicarbonate is CO2 driven or passive and is not metabolic alkalosis. When PaCO2 decreases, the reaction shifts left to produce more CO2 from hydrogen and bicarbonate. The bicarbonate then falls, but again this is a CO2 related lowering of bicarbonate and not metabolic acidosis. So in both the cases, the change in bicarbonate is the after effect of change in CO2. Now let's see what happens when the reaction starts from the metabolic side. The metabolic side contains hydrogen and bicarb. When there is excess hydrogen as seen in metabolic acidosis, the reaction shifts left. Hydrogen reacts with bicarb to form carbonic acid, which then dissociates into water and CO2. The CO2 is then excreted via lungs, indirectly removing hydrogen ions. Now in this case, bicarbonate is lowered due to non-respiratory cause. And the lowering of bicarbonate does not always have to be due to excess hydrogen, but it can also occur due to excessive renal excretion of bicarbonate. When hydrogen is lost, as in metabolic alkalosis, the reaction shifts right to replace the lost hydrogen ions. This shift releases more hydrogen into the blood to help restore normal pH. But because the equation always releases hydrogen together with bicarb, it also increases bicarbonate level, which is why bicarbonate level rises in metabolic alkalosis. And as a simple logic as it is, adding alkali adds to the concentration of bicarbonate and the system again shifts to the right to generate hydrogen to neutralize it. So in both metabolic acidosis and alkalosis, the cause can be pinpointed to the metabolic component of the reaction. It was never a respiratory or PaCO2 that caused the change in bicarbonate. And this change in bicarbonate concentration, independent of the influence of respiratory component, is expressed by base excess or base deficit. The focus now is entirely on the metabolic component. Now, how do we isolate the true metabolic disturbance? Because at any given point, the bicarbonate value we get is the result of the combined effect of both the components. Well, we do this by artificially setting PCO2 to 40 mmHg or normal, making the respiratory component constant. For this, we use this equation. I don't even know the proper pronunciation for it. Anyways, this equation compares the patient's bicarbonate level to the normal value, where a positive value suggests metabolic alkalosis and negative suggests metabolic acidosis. The last part of the equation adjusts for the non-bicarbonate buffer effect from buffers like proteins, phosphates, and hemoglobin. 0.9287 in the start of the equation is just an empirical correction factor derived from the experimental data to improve accuracy. And prior to this formula, experiments were used to measure the amount of acid or base added to normalize the pH to 7.4. If the acid was added, it was called base excess, and if base had to be added, then it was called base deficit. This is the reason why the base excess or deficit is defined as the amount of strong acid or base needed to titrate a blood sample to a pH of 7.4 under standard conditions of 37 degrees Celsius temperature and PaCO2 of 40 mmHg. From the clinical standpoint, the normal base excess is expected to be within -2 to +2 MEq per liter. Base excess more than +2 MEq per liter indicates metabolic alkalosis, which means that there is an excess of base or loss of acid. Base excess lower than -2 millimole per liter or MEq per liter indicates metabolic acidosis or excess of acid or loss of base. Negative base excess is also called base deficit. In both the situations, the more the value deviates from the normal value, the more is the severity of the condition in question. In conditions like trauma, sepsis, and shock, base excess can indicate tissue hypoxia earlier than lactate level. When oxygen delivery fails, tissues shift to anaerobic metabolism, producing lactic acid and causing metabolic acidosis. Lactate levels may take time to rise and depend on the liver and kidney clearance, so they can be normal early in shock. In contrast, base excess, calculated from pH, PaCO2, and bicarbonate, reflects the total acid load immediately. This is reflected as a negative base excess or base deficit. In clinical practice, the base excess level that suggests shock or tissue hypoxia is typically less than -5 millimole per liter. Further, the severity can be categorized as base excess between 6 to 9 millimole per liter, suggesting moderate shock, and base excess less than -10 millimole per liter, indicating severe shock and often linked to high lactate and organ dysfunction. Some clinicians give sodium bicarb if the pH is below 7.1 and base excess is less than -6 millimole per liter. This is common in renal failure where the kidneys can't make enough bicarb. It can also be used in poisoning like TCA overdose to make the blood more alkaline and reduce toxicity. Bicarbonate, however, is not used in all the metabolic acidosis. But in some cases with large base deficit, it may help. The decision depends on patient's condition and risk. Finally, base excess can help monitor treatment. A base excess trend towards zero shows that the metabolic problem is getting better. If base excess improves over time, it means resuscitation or treatment is working. This is useful in shock, sepsis, or after giving fluids and drugs. On the contrary, stable or worsening base excess may suggest ongoing acidosis or poor response. That's all, and with this, I end my video series on ABG analysis. If you have any queries on ABG analysis, feel free to ask me in the comment. I'll read on it and make sure to answer it to my fullest capacity. Thanks.